Hi, this is Dr. Jin, medical oncologist as well as an assistant professor at The Ohio State University. It is my greatest pleasure to give the talk regarding the update on the gastroesophageal cancer care and research at OSU. First, let me introduce our GI medical oncology team. We're having a total of 8 providers taking care of cancer patients with GI malignancies. For today's talk, I will start with the incidence and survival of gastroesophageal cancer, briefly explain the diagnostic process, but focus on the treatment of localized gastroesophageal cancer based on anatomic location, highlighting the ongoing research for gastroesophageal cancers at James. Then we will end with the treatment for stage 4 gastroesophageal cancers. First of all, there were 2 types of esophageal cancers. One is called adenocarcinoma, originating from the gland in the esophagus. The other is called squamous cell carcinoma, originating from the lining of the esophagus. There are 2 different cancer types in esophageal cancer regarding their etiology, cancer biology, patient population, as well as the treatment. In this map, we can see that in the United States, men are more likely to be found with adenocarcinoma rather than squamous cell carcinoma. However, worldwide, the squamous cell carcinoma is more prevalent, especially in the Asian countries. For the United States, over 40 years, there's an increased incidence of esophageal adenocarcinoma, likely due to the prevalence of obesity and gastroesophageal reflux disease called GERD. GERD can lead to Barrett's esophagus, which leads to chronic inflammation and injury, and can evolve into cancer formation. Regarding squamous cell carcinoma, it is more associated with alcohol, smoking, and processed food, as well as hot beverages. In the United States, in women, females are more likely to have squamous cell carcinoma rather than adenocarcinoma. However, in general, female patients have less incidence to have esophageal cancer. This bar graph showed that the incidence rate of esophagus and stomach cancer or gastric cancer is less compared with other GI cancers, like pancreatic cancer and colorectal cancer. However, the 5-year overall survival for esophageal and gastric cancer is significantly poor compared with colorectal cancer. So we may wonder, what is the reason for poor outcome for esophageal cancer? As a matter of fact, about 40% of patients are diagnosed with stage 4 gastroesophageal cancer. So the accurate staging is essential, which includes EGD, which is a procedure inserting a scope through the stomach. It's a flexible tube with a camera attached to the end of it to examine the esophagus, stomach, as well as the first portion of the small intestine. We need to have a biopsy to prove the cancer. Also, we need EUS, so-called endoscopic ultrasound, for accurate tumor staging as well as lymph node staging. In general, we favor PET scan to rule out cancer spreading to the other place, so-called metastatic disease or metastasis. Very often, surgeons will need laparoscopic exam to rule out disease spreading to the peritoneum, which is the lining of the bowels. The reason to do the laparoscopic exam is that there is a high propensity of cancer spreading to the peritoneum in gastric cancers. This is the study I took from the journal Nature, published in 2017. Scientists analyzed more than 500 tumor samples collected from patients with esophageal, GE junction, and gastric cancers. The GE junction cancer is the cancer where the esophagus meets the stomach, involving with the GE junction anatomical feature. The take-home message from this study is that the upper esophageal cancer is consistent with squamous cell carcinoma, which highly or closely resemble the head and neck cancer. Second, the GE junction adenocarcinoma has striking similar features with the subtypes of gastric cancer, so-called chromosome instability or CIN, which means the chromosome gains or loss. Therefore, when we conduct clinical trials for gastroesophageal cancer, we always divide patients into two groups: squamous cell carcinoma versus adenocarcinoma. Let's talk about the current treatment paradigm for esophageal and GE junction cancers in the United States. In very early stage, patients can undergo surgery through endoscopic resection. For patients with localized esophageal and GE junction cancers, in which case there were lymph nodes involvement as well as multiple layers being involved in the esophageal wall by cancer, patient will go through the concurrent chemoradiation before going through the surgery. So this is a landmark study, so-called cross trial, published in well-known journal, New England Journal of Medicine in 2012, as well as the update from Lancet in 2015. So the cross trial accrued patients with squamous cell carcinoma or adenocarcinoma of the esophageal and GE junction cancers. A group of patients go to surgery alone. The other group went through chemoradiation before going through the surgery. From here, we can tell the patient outcome in these two different groups of patients. So this is called overall survival plot. To understand how this plot works, we will start with the x-axis. So on the x-axis, we'll start with 0 all the way to 96. That means we followed patients in different periods from starting the trial all the way to the end of the trial, which is 96 months. On the y-axis, it's the percentage of the patients who were alive at different time. For example, let's say at the beginning of the study, all the patients, 100% of patients were alive. However, as the study went, there were some patients who experienced the incidence of death. Then the curve will go down. So it's a downtrend pattern. There's also a blue line versus the red line. The blue line represents the patient group who underwent so-called neoadjuvant chemoradiation before the surgery. Neoadjuvant means that chemoradiation happened before the surgery. And then the red line resembles the patients who received surgery alone. When we draw the cross line through that 50%, we can see that patient received neoadjuvant chemoradiation has better outcome, has a longer survival compared with the patients who received surgery alone. At James, we have ongoing clinical trial to ask the question, how can we improve the treatment for patients with esophageal or gastric G-junction adenocarcinoma who are not surgical candidates? In these cases, the cancer is too advanced so that surgeon cannot do the surgery. So this is a phase 1 study with expansion cohort of this OBP301, which is an oncolytic virus, in combination with chemoradiation for patients with locally advanced esophageal and gastroesophageal junction adenocarcinoma. We formed a multidisciplinary team with radiation oncology, medical oncology, and advanced gastroenterology. So the rationale for the study is that the oncolytic virus OBP301 is injected into the tumor by the gastroenterologist. These viruses will replicate in the cancer cells and then lyse the cancer cells and trigger the immune response. When the cancer cells die from lysing by the virus, it will release abnormal protein and trigger the immune cells to say, gee, they're not normal, they're abnormal cells, and let's take care of them by destroying them. So this is called anti-tumor immune response. In the early phase study, this virus OBP301 was combined with radiation in Japanese group. it showed that this virus is very safe and toxicities are manageable without concerning complications. So OBP301 may sensitize the infected tumor cells to radiation due to the DNA damage. In addition, this virus may also potentiate the systemic anti-tumor immune response, which may also help the distant spreading, to prevent the distant spreading. So the trial design for this multi-center NRG study include the treatment flowchart. EUS and PET scan patients need to go through the chemoradiation with intratumor injections of this oncolytic virus, total of 3 times of injection. After completion of the chemoradiation, patient will undergo the EGD as well as the PET scan for surveillance and be followed up with certain periods of time. The key inclusion criteria include adenocarcinoma of the esophagus or G junction within 90 days prior to enrollment. Patients must have good physical activity. We call that as performance status of 0 to 1. Must have a tumor that is amenable to intratumor injection. Patients must have been evaluated by thoracic surgeons and deemed as not a candidate for surgery, but as a candidate for chemoradiation. Also, patients must have adequate blood, kidney, and liver function. So if you are interested in this study, please consult your treating physician before the trial enrollment. Now, let's switch to the treatment paradigm for gastric cancer in the United States, which is far apart from the location of G junction. The early stage gastric cancer or stomach cancer, patient can still go through the endoscopic resection or surgery pioneered by Japanese group. For localized gastric cancers, majority of patients will undergo chemotherapy for 3 months, followed by surgery, then followed by another chemotherapy for 3 months. Sometimes the patient may present with acute bleeding due to the tumor erosion to the blood vessels or other emergent situation. So surgery may happen before the adjuvant chemoradiation. I took one of the best study for gastric cancer, so-called FLOT4, which is published in Lancet 2019. In this study, there were 2 groups of patients for gastric cancer. One group received FLOT, F-L-O-T, which means the chemotherapy combination favavir, oxaliplatin, and docetaxel. The other group received the chemotherapy called ECF or ECX, which means a combination of epirubicin, cisplatin, and favavir, or epirubicin, cisplatin, capecitabine. From this overall survival plot, we can see that the red line which indicates patients who receive the flat treatment have better overall survival compared with patients who received the ECF or ECX. However, there's still a room to improve the patient outcome for gastric cancer. In reality, majority of patients will suffer some sort of complications or side effects from the surgery, resection. Lots of patients will have challenges with decreased energy level, weight loss due to the lack of nutrition because difficulty in eating after the surgery, or other type of complication like infection. So a lot of patients cannot receive the full total months of chemotherapy or need some dose reduction of the chemotherapy, especially in their post-operative chemotherapy months. So at James, we have developed another clinical trial to ask the question, can we put the chemotherapy and the radiation upfront before the surgery? So this study is called Total Neoadjuvant Therapy for the Treatment of GE junction and gastric cancers. Once again, involved with medical oncology, radiation oncology, surgical oncology, and radiology. So the rationale for this total neoadjuvant treatment is that we know both chemotherapy and post-operative chemoradiation can improve the patient outcome compared with surgery alone in gastric cancer. Putting chemotherapy and chemoradiation upfront before the surgery will ensure the full delivery of the chemotherapy and other treatment. And this may be feasible and safe in gastric cancer. Also, we will use digital PET imaging to adjust the treatment volumes with a boost that has the potential to decrease the radiation toxicity. So the treatment paradigm include the baseline PET scan before the chemotherapy. The chemotherapy is about 2 months, followed by the second PET scan. The second PET scan is to analyze the response, also define the boost volume for the radiation. Then, after complete the chemoradiation, patient will have the third PET scan, which to make sure there's no disease progression before going through the surgery. The key inclusion criteria include patients with biopsy-proven gastric or G-junction adenocarcinoma. We highly recommend patients undergo the EUS endoscopic ultrasound and staging laparoscopy before the enrollment. Patients must have a good or adequate performance status, good physical activity, and must have adequate blood, kidney, and liver function. Once again, please consult your treating physician before the enrollment. At the end, I need to focus on or discuss the systemic treatment options for stage 4 esophageal, G-junction, and gastric cancer. we'll call that as upper GI cancers. When patients come to clinic, we always want to thoroughly evaluate patient physical activity, performance status, their medical problems, as well as the cancer-related symptoms, such as the pain, loss of appetite, loss of weight due to difficulty in eating. And we should maximize the support so that patient can receive the best care. Unfortunately, some patients, especially elderly patients, they are already very weak when they had the diagnosis of stage 4 cancer, gastric cancer. And in those patients, chemotherapy is contraindicated because of side effects, and palliative care or hospice is more appropriate for those patients who are not candidate for systemic chemotherapy. Also, clinical trials is always recommended or encouraged in first line, second line, and third line treatment. The first line chemotherapy is usually involved with 5-FU based chemotherapy with or without trastuzumab, which is target therapy for HER2. The second line of chemo is paclitaxel and ramucirumab versus immunotherapy if their PD-L1 score greater than or equal to 10. I will explain the PD-L1 protein in the next slides. And then the third line treatment is either immunotherapy or irinotecan or chemo pill called TAS-102. So anti-PD-L1 therapy or immunotherapy, or sometimes we say immune checkpoint inhibitors, have transformed the oncology care in many types of cancer, including melanoma, lung cancers, as well as upper GI cancers. So what is PD-L1 protein? It's a protein that is expressed on tumor cells. As host defense mechanism, our immune cells, such as T cells, will constantly screen for foreign invaders as well as tumor cells to destroy them. However, this PD-L1 protein is expressed on the tumor cells and help the tumor cells to mask themselves to escape the immune surveillance. It triggers the immune cells to undergo and pass them by putting invisible clothes to escape the immune surveillance. This way, the tumor cells will continue to grow. The drug called Pembrolizumab is an antibody that binds the PD-1 and prevent PD-1 from binding to the ligands on the tumor and the T cells. This way, the T cells can be activated again and start to destroy the tumor cells. It has demonstrated robust anti-tumor activity, and the side effects are usually manageable. The immune therapy is very different from chemotherapy, and in majority of patients, we have a very good safety profile for immune therapy. But still, patients may suffer from fatigue, some skin rash, as well as thyroid function abnormality in general. I took this study, so-called Keynote 059, published in JAMA Oncology 2018. This study accrued patients who had received at least two prior chemotherapies before receiving pembrolizumab in Junction and gastric adenocarcinoma. This study turned out that patients had a very good response, about 15% response rate if they have PD-L1 protein present on their tumor. So pembrolizumab is approved in third-line setting for patients with G-junction and gastric adenocarcinoma with PD-L1 score greater than or equal to 1, meaning protein present on the tumor. The second study I took is Keynote 181. This is a global study conducted in patients with esophageal and G-junction and gastric cancers, stratified by squamous cell carcinoma as well as PD-L1 score. We found that patients with squamous cell carcinoma or patients with PD-L1 score greater than 10% has a dramatic improvement in overall survival compared with patients receiving chemotherapy. The median overall survival is 9.3 months for patients receiving pembrolizumab versus 6.7 months in patients receiving chemotherapy. Therefore, pembrolizumab is approved in second line for patients with esophageal squamous cell carcinoma with a PD-L1 score greater or equal to 10. In terms of squamous cell carcinoma, there is no great second-line treatment for this type of cancer. So we think this is an advancement or improvement in cancer care for esophageal squamous cell carcinoma. As a conclusion, the treatment of gastroesophageal cancer is complex, however, with unfavorable clinical outcomes. At James, we have developed a multidisciplinary team to conduct clinical trials to improve the treatment efficacy in upper GI cancers. And last, immunotherapy holds the promise in this field, and then there will more come in terms of new studies in the next year to come. And thank you, and I appreciate your time, and I hope you enjoy my talk. Thank you.